All right, good afternoon, everyone. Welcome to September's QIC. So first of all, there we go. I went through the cases that we were sent in for August, and overall, first of all, big kudos to everyone. I was very impressed with the level of care that was provided for patients in those cases. There was a lot of very clear emphasis on trying to do best stuff for the patients, and the documentation overall was very good. There's also a lot of sick cases over the course of that month, including several cardiac arrests, which we are not going to go over today. Put a pin in that. We'll come back to those on a later date. The other thing that came up from August was, of course, VOA. And thanks to everyone again for all the hard work on that. The notes that came from VOA patient transfers, I thought those all went overall very well. Yeah, that's my big kudos to everyone for the last month. So pat on the back. Today, I've got a collection of cases that all have kind of a similar pathology that we're going to go through. And they all have one major underlying pathology. I think there's like 6 in total that ended up coming up on my list of cases to review. So I wanted to go through the narratives for those as a compare and contrast discussion. So first one, you got a patient, group ladder 75 that got sent out for a stroke. For this, and with the chief complaint of stroke as a concern. When the crews got there, patient was sitting in their dining room. Noticed there's a significant slurring of speech, not able to understand her very well. Does have equal arm strength and is able to walk to the cot without a ton of assistance with that. Some facial droop present. She had a 12 lead and an IV done, and you can see her vital signs where she's slightly hypertensive. Given the very elevated diastolic blood pressure and kind of very narrow pulse pressure, I wonder if that blood pressure might be spurious, because oftentimes when it's that tight, it's more so a problem with the blood pressure cuff as opposed to that being the actual patient's native blood pressure. So if you see something like that, it's okay to run it again and see if you get something that is consistent with that, and make sure your cuff size is appropriate for a patient's habitus. Otherwise, the crew got a IV on her successfully after a couple attempts, got a 12 lead that showed a bundle branch block with no STEMI, and brought her to Westchester. No other big changes en route for her, and she was treated as a stroke at Westchester, taken to CT scanner, etc. This next one was paged out as concern for a possible stroke, and the ultimate diagnosis that was given for it was a TIA. So older patient, history of Parkinson's, and had TIAs in the past. And family members are visiting and noticed that she also had slurred speech and some facial droop that happened about 5 minutes prior. By the time our crews got there, she was pretty much back to normal. She was able to ambulate appropriately and was having some improvement in her symptoms. She did get a blood sugar done, got IV done, got a 12 lead done, and again, her blood pressure, she's known to be a little bit hypertensive without tachycardia, and was taken to Christ Liberty. This third one is another stroke, patient sitting in her chair. Last known normal was around 8 a.m. in the morning, and now at 11 a.m. they saw that she'd gotten better, and now at 1:30 in the afternoon she was not feeling very well again. The interesting thing is that she had been hospitalized a few days prior, and there was concern that she may need to start taking aspirin again, which she had been instructed to do, but not on any other blood thinners. There's concern for possible stroke for her with those other symptoms. Ended up taking her to the hospital for management. Otherwise, she also was a little bit hypertensive, 12 lead done, IV done, glucose, etc. This one, I was very happy when I read. This one was dispatched out as concern for a fall. And on this one, it was a 95-year-old who had what sounds like a ground level fall out of the wheelchair and then hitting the ground with a brief loss of consciousness. In this, there was concern that patient had having some altered mental status for the last couple days. When they got there, saw that he was had no clear signs of significant trauma, but was Cincinnati stroke scale positive with some slurred speech. So he got a blood sugar that was checked on him, had vital signs run, got a 12 lead, and was taken to Westchester Hospital for assessment. And this is another one of a fall where there was a patient who had a ground level fall, so relatively low mechanism, And when they got there, patient was having some slurring of speech, able to nod their head, but patient was having difficulty with speech overall. Appropriately, patient had a C-collar that was placed, was assessed with Cincinnati Stroke Scale that was positive, and on that had some significant whole body right-sided deficits. And then a little bit of left weakness as well. Patient got taken to hospital as well, got sugar. This one I believe did not have a blood sugar done, but did check heart rate. And this one also, there was some difficulty getting blood pressure cuff to read on this patient. And this one went directly to CT scan, given low mechanism of trauma, but then also these significant neurologic derangements. And I think this is one of the last ones where older patient who was described as a sick person, found patient seated on the bench, oriented to self and event, but patient and protecting airway appropriately. Patient, however, noted to have some weakness on the left side and some asymmetric smile upon testing, and some confusion with what sounds like some dysarthria present. And this patient got taken to Westchester Hospital and got seen at the door by the ED doc with concern for potential stroke. This one had a blood sugar that was done, and again, you'll note a little bit hypertensive, but also tachycardic as well. And I believe this one is, yep, this is the last one that I had. Another one dispatched as a possible stroke. So this one, there was a headache and high blood pressure present, and then the patient started to become altered and had some slurred speech. And interestingly, does have a history of a TIA as well as diabetes in the past. So when our crews got there, know that the headache had gotten slightly better, patient's mental status had improved, had an appropriate blood sugar overall, and patient was then brought to hospital for evaluation. And then again, on this one, fairly hypertensive, but without other significant vital sign derangements, but does have a slight change in GCS. So going through all of these, the big thing that I think is worth noting is that the variety in presentations that end up coming up with concern for stroke patients. And we'll talk about this a little bit further as we get into some more of the actual review process. But overall, the thing that I was very impressed with was the high concern that was present for potential underlying neurologic deficit for these patients, including ones where that was not the chief complaint that was caged out. It was fall or a patient who's just not acting normally. And as part of like actually looking at the patient, these were picked up and appropriately had an appropriate level of concern with them. And I liked overall the description of the events, the progression of what was going on with these patients, et cetera. A couple like nitpick points on the documentation side. If you have concern for any neurologic deficit, I'm a big proponent of getting a glucose. It is a very, there's a low cost test. It's not that hard for people to do most of the time, but it does help at least like get an idea of what their blood sugar is. It's not uncommon for patients with a neurologic insult to have a slightly elevated blood sugar as their body's kind of stress response to something wrong. But we never want to miss a hypo or a severely hyperglycemic patient causing these changes in mental status. The other big things when you're asking people around, including the patient, if they're able to provide it, is in regards to their medical history. Biggest one we always worry about is blood thinners, because that could be a potential contraindication for them getting thrombolytics, so TNK or TPA. And then the other things is, do they have known risk factors for cardiovascular disease? So this will be things like, have they had strokes or TIAs in the past? Do they have a history of heart disease as well? Because usually these people have diabetes, high blood pressure, diseases of their heart or diseases of their brain, had in the past, they can do it again. And there's a very high likelihood that they can progress to a worse state of disease as these processes go towards their typical end. Last known well is critical for patients if you can help getting that. And oftentimes patients that come in with like a known last known well, or I know that some people use like the stroke stickers that you can write that down, as well as a contact information for family members. That is insanely helpful on the hospital side because that last known well determines the patient's eligibility for getting interventions. So if you guys are able to get that on scene, that helps us make a decision about, can this person get lytics and or can they get thrombolytic or thrombectomy interventions. And if there's a person that you can get their phone number down for us to call in a first name that we can help verify that information, oh my God, gold. You guys would get coffee from me for most of that. And then the other thing that's actually really important is to understand the progression of symptoms. Some of the cases that we had here would sound more like a TIA, where they had neurologic symptoms, then they started going back to normal. That is also helpful because that's actually one of the exclusionary criteria for people getting thrombolytics, because we don't want to expose them to the risk of that medication if they haven't got like a true full-blown clot. But TIAs is basically the precursor for people to go into a potential stroke at some point. So that is.
Fire alarm.
Hi guys. Hi. Be safe.
Fire alarm. Coordinate places right like Preston Crossing from Cohesion Rail to the road.
But the thing with patients, if there are signs of a TIA, that is something that we end up treating very aggressively with trying to do risk modification for patients. And sometimes as part of their workup, we'll find a very critical stenotic lesion or area in their brain's blood vessels that has a high likelihood of progressing to stroke, and we can potentially intervene on that before they get severely sick. So understanding how these things came on, how long they last is actually very helpful. In your documentation, I'm a big advocate for when you write down the GCS, to make note of why you took the points off that you did. The most common ones in patients with neurologic deficits is going to be the verbal. They're slightly confused. So the second one that you'll hear most often is they'll have one off for eyes, where if they hear sound, they will open their eyes for it. But it's good to note what those are, so it helps clue you into the severity of the neurologic deficit. And then the last one is documentation of the neurologic exam. And from my year at Air Care, working with docs who are documenting this, I can honestly say no one documents a neuro exam well. And it is actually
routine now showing intersection of toxide and speed mode.
It's one of the things that I think most of us need a fair amount of
the number back, no contact.
Reminder on how we do it. We do it well. This is my like typical neurologic exam for someone, just a normal patient who doesn't have underlying neuro problems when I'm flying on a helicopter or when I'm in the field. And I'll usually like ask patients like smile and make sure they can raise their eyebrows to look for that symmetric forehead range. Is their speech fluent when I'm talking to them? Have them stick out their tongue. And then I will have them move their arms or their legs, and then at the same time touch both of their hands and both of their legs as a very quick assessment of their overall sensory function. And if they can walk for you and you see them have any type of ambulation, that is actually really helpful as a way to assess their overall coordination and look for signs of ataxia.
Around 10.
Too far. In your patients who you have concern for underlying neurodeficits or stroke patients, and you're trying to figure out big things for documentation, the goal is describe what you're seeing for them while kind of interrogating their brain to try to see what areas are involved. Some of the really good charts that I've read even talk about what they saw in their patients. So they saw that their face was having some droop with it, saw that they were not able to grip appropriately between their two hands, and that's incredibly valuable. I would challenge everyone to try to do something similar when you see seizure patients, because the seizure semiology can actually help us determine what type of part of their brain is affected, if it is a neurologic seizure or not. So like people oftentimes write like a grand mal seizure. If you can describe that you see their whole body was twitching, or they were having like hip thrusting with it, you saw that they were having eye movements towards one side or another, that's actually really helpful information on our side, especially if those symptoms improve prior to them getting to the hospital. And same thing on the TIA side as well. If you saw them having signs of like they had left-sided facial droop, and then they had some difficulty with speech, that can also help clue us into what side of the brain is affected. When we go look at the blood vessels, it'll help us give us an idea of where we need to look. And then we'll dig into this a little bit later. I'll see if Cody is willing to be my my willing model for some of this. All right, so on to strokes and TIAs, that is the topic for today. And thankfully Dr. Richards here, who is far more of an expert than this than I am. But
I didn't even put you up to this.
No, you did not. So I am going to defer to any of his commentary and introductions as well, since he is our resident stroke pre-hospital expertise gentleman. So just for everyone's awareness, if it seems like you see this a lot, it's because we do. Strokes are incredibly common. About 800 patients annually according to Rosen's, end up having this diagnosis, and it's one of the fifth leading causes of death and a very common cause of long-term severe disability for patients. And it's a super common EMS call, especially with all of the public information and PSAs that have gone out about FAST and stroke recognition to help the public understand some of the things that they're looking for. Stroke in general, basically what it is we have some type of vascular injury that ends up reducing blood flow to a neurologic tissue. I say that specifically because most of us think of a stroke of the brain, but there's two other neurologic tissues that can also end up having strokes, and one of them is the retina, and then the other one is the spinal cord. Those we don't see as often, but they are something that can happen for people. As we're aware, most of us know that there are two types of strokes. We have ischemic, which is the far more common one. And this is where you actually have typically a plaque inside of the blood vessel itself that ends up narrowing the lumen of the blood vessel and eventually clotting off to where blood is no longer able to flow through, or an embolic form of an ischemic stroke where you have a clot that gets flipped off from elsewhere, oftentimes the left side of the heart, and then goes up into the brain and clogging off the blood vessel so that it's not able to have blood continue to flow through it. The other type of stroke, less common, but just as severe, if not more severe for a lot of patients, is hemorrhagic. And this is where you have a blood vessel, usually smaller ones, deeper in the brain structures, that have, due to these like cardiovascular insults, have a lot of pressure in them that then it causes a weak part of the vessel to break and then bleed into the brain, leading to them having neurologic deficits, brain damage. And I've seen some of these end up being incredibly debilitating to patients, leading to them dying very quickly. The other thing to be aware of is that not all strokes end up having that snap their fingers, boom, all of a sudden they're down. You can have some people, just like with heart attacks, where they have a little bit of a stuttering process, where they have episodes where they're a little bit better, then they get worse, better, worse, as they have that small blood vessel that is involved, and then eventually gets occluded, or as blood continues to accumulate inside of their brain, pressing on more structures of their brain and causing defects for them. On the cellular level for patients, when you have this insult that causes loss of blood flow, you have this overall decrease in the cerebral blood flow. And as a consequence of that, the brain tissue loses oxygen and it loses glucose in its normal quantities. And as that loss of blood flow gets worse and worse and worse, this becomes more and more severe. The body may try to raise its blood pressure to try to help force blood and oxygen into this affected area, which is why for a lot of patients that have stroke, you'll end up seeing them being hypertensive as their body's trying to overcome its inability to perfuse that part of the brain. The area that's affected in the brain, it will end up losing some electrical activity as it loses that oxygen and glucose. It's not able to run its cellular functions. And that's why we end up seeing the symptoms that we do where patients are flaccid or they're not having that innervation from their brain. This eventually progresses to cell death in the area that is ischemic, which will then cause those cells to break open. Oftentimes it will end up releasing some inflammatory markers that causes swelling in the brain area and leads to a whole host of other worsening symptoms for patients. There is a part of the brain that we call the penumbra, and it is basically the surrounding area of the affected stroked out area that gets some extra or collateral blood flow from other blood vessels. When patients have had a stroke, this is the area that we want to preserve as best we can to make sure that that area has a healthy recovery. If we can save the main part that's stroked out, fabulous, but we can't always. So we want to make sure that we focus on making sure that that penumbra or that salvage a part of the brain is protected so the stroke doesn't get worse over time. Hemorrhagic stroke ends up having similar end products for people, but just as a reminder, it's usually a rupture of blood vessels inside of the brain. It has a couple of its own little caveats. Usually it ends up being in the deeper structures of the brain, like in the thalamus or in the, I'm trying to remember some of the other areas, like the internal capsule for patients in the brain. So often on patients, you won't see this collection of blood on the outside like you would for a epidural hematoma or a subdural hematoma, but it ends up being in the deeper structures. And the problem is that this is a very high real estate area. This is very near where parts of the brain, such as the brain stem, are that help control our ability to breathe. And it's also where a lot of our tracts from the brain of neurons end up leaving the brain. So as this area swells or the bleeding continues, it'll end up pushing on these parts of the brain and end up causing those other areas to become ischemic or cause herniation syndrome, where as that blood expands, it pushes further parts of the brain out and causes further compression on the brain stem, the midbrain, kind of the more primitive brain that helps us stay alive. So in these cases, our focus ends up being on trying to control the severity of bleeding. That's why these patients, you'll see us be really aggressive with blood pressure management. And sometimes they also need to have a drain put in to get some of this fluid out of that area, as well as reversing any blood thinners that they're on, so that if they have any chance of clotting and stopping the bleeding, we can do that effectively for them. This is, I want to spend a couple minutes going over the actual anatomy that goes into strokes. As a reminder for everyone, the blood vessels or the blood flow to the brain is controlled by two major groups of arteries, the carotids and the vertebral arteries that come off of branches of the aorta. The carotids end up going the anterior part of our neck and then split once they go inside of the brain, creating our middle cerebral artery as well as our anterior cerebral artery. And that ends up controlling a lot of the forebrain functions. The vertebral arteries come up through the vertebrae themselves. They end up meshing together to form the basilar artery, which is where we get some of our posterior physiology and blood flow to the brain. So usually the larger usually the larger parts of our hemispheric brain, so like the frontal lobes, the parietal lobes, those will be supplied by more of this anterior circulation coming off the carotid blood flow, and then things like the cerebellum or the brainstem will be supplied by the basilar and posterior circulation. This is on the brain itself. So you can actually see this is the basilar artery on top of the pons here, and then this is the vertebrae as they come and form together right on top of where the spinal cord exits the brain next to the cerebellum as well. And then here's your internal carotids going, and then they break off to give you your middle cerebral artery, and then they come forward here to create your anterior cerebral arteries. Together we call this whole thing the circle of Willis, because we think this whole thing looks like a circle, kind of with a bunch of branches off of it. And each of these vessels that end up having an effect on them, if they have a stroke, so say the middle cerebral artery, because this area ends up perfusing a large chunk of brain, and it's a very specific pattern of that area of brain, they cause their own syndromes that help us clue us into what vessels are affected. One of the things that I do like to remind people of is this terrible drawing, but the homunculus of the brain. As you go along the sides of the brain, this ends up innervating more of the face as well as the mouth. But if you go up into the center of the hemispheres on the brain, this gives us more of the innervation for our lower extremities. And this ends up correlating with why we see middle cerebral and anterior cerebral arteries impact what they do. So your middle cerebral artery ends up perfusing more of this side of your brain, which is why you'll see them end up having upper extremity deficits, difficulty with speech, difficulty with moving their face. But patients who have just an anterior cerebral artery, they'll end up just having leg involvement predominantly. So each of these vessels, as they get included, cause a very specific syndrome. The anterior cerebral one ends up causing, usually for people, you'll see them having some more effect in the leg. And you may see some difficulty with bowel and bladder function as well, just because of the area that is innervated with it. Most of us are familiar with that middle cerebral artery syndrome. This is where we have difficulty with the upper extremities. Patients will have facial droop with it. They'll have some difficulty with speech, either dysarthria, where they're not able to form the words correctly, or aphasia, where they're able to form words, but it is essentially a word salad, or they have difficulty with word retrieval and creating inappropriate verbal response. The other thing is that in that middle cerebral artery one, you can, because of where the visual tracts cross through, you can end up having a gaze preference. So patients will not be able to look past midline or have a complete hemi-neglect where that part of their body that is infarcted off, they basically don't think that it exists. Posterior cerebral is a little bit more special. I haven't seen a lot of those strokes, but most of them will be with things like blindness is the one that we think about the most commonly associated with it. One thing to bear in mind too is if you have a stroke that's more proximal, so it takes out their internal carotid or takes out their vertebral arteries, such as in like a vertebral dissection, you may see all of these together at once. And that raises concern for a more proximal lesion as ends up being a more severe stroke.
When they're talking LVO strokes.
These are LVO strokes, yep. So these are all the LVO syndromes or large vessel occlusion syndromes. You can have strokes in areas that are much smaller blood vessels, and these need to be more specific, like just their hand function or like maybe just like part of their face, and we may not see that occlusion of like a larger blood vessel, but it's still classified as a stroke because you still have that pass-through with it. The one that everyone gets tripped up on is posterior strokes. And this is going to involve things like your basilars as well as your vertebral blood flow. Basilar strokes, they're the ones that I fear the most, and they mostly because they end up having a severe dysfunction for patients. This is the ones that end up causing locked-in syndrome, where patients still have retained their higher cortical functions. They're still able to understand what's going on around them, but the only thing they can move is their eyes. So oftentimes these patients end up needing to have like a trach and a peg. When you go up to them, they may have some seizure-like activity, where as you pinch them, they end up having some decorticate posturing for about 30 seconds that then resolves due to this disruption in these neuronal pathways. And then the other thing to be aware of is in the posterior strokes, these are patients that typically present with dizziness, and they may have some hearing changes because of the innervation of that part of the brain. But the biggest thing that we'll run into with them is dizziness and ataxia. So this is where you'll have patients where you try to get them up to walk and they're not able to do so. They look like they're drunk because that part of the brain causes us to have our equilibrium or our sensation of where we are in space and maintain our balance. Anything on those I'm forgetting?
No.
The one question, docs, that I have for you is, obviously, we've been getting or seeing more of these dizzy type cases that end up being posterior strokes. What, obviously, based off of normal stroke assessment, they're not going to necessarily be caught. What is kind of the telltale golden standard currently? At what point do we say, no, we need to go closest facility that's stroke capable versus maybe taking them to a further away hospital or taking them to a hospital that's not stroke capable? What would your decision or recommendation be on this?
This is why I struggle with the NIH stroke scale for people, because you're right, it does not clue in posterior strokes really much at all. So on my own assessment for patients, if I can, I walk them. Because if usually for the ones that I've seen that have some posterior stroke involvement, they'll end up having significant ataxia, and that's a really big clue. The other thing that you can look for is like severe dizziness. Granted, I'm still a younger attending, but like any patient that has dizziness that particularly it's dizziness where they end up having their eyes closed and they still remain dizzy, or you see them having like a ton of eye movement with it. I usually treat that as a posterior stroke until they've had imaging to show me that that part of their flow is appropriate still.
So
Becky Richards.
based off of that, kind of like if we were to, because our crews do a good job assessing, like it's visible in their documentation.
Mhm.
So if our crews have that where they close their eyes, they're still dizzy, like something just doesn't seem like it's adding up, recommendation would be to go closest stroke.
Yeah, I'll highlight a lot of what you said. Probably if you're at the point where like you're calling 911 from vertigo, is probably something where like a posterior circulation stroke should somewhere be on that list. And I think a stroke center destination is probably right. Yeah. Things that kind of get me. Well, one thing that I'll say is all the scales that we look at, Cincinnati and almost all of the severe stroke scales are far more weighted toward anterior circulation.
Yes.
Stroke. And so you could have a really bad disabling stroke in the posterior circulation, and it may not even hit the screens that we do. Maybe it'll hit like 1 point or something like that. So that's why I think it's so important to have that clinical sense and kind of fall back on this, right? Because this is really kind of where the clinical acumen kind of comes into play, or cases like this. So things that I would have you all take a look for. So one is like Phyllis that you said, which is like sudden severe vertigo. It's closed eyes. The other thing that kind of gets me when I'm having these conversations in a stroke call is certainly walking ability, but then also, even if you don't want them to walk, truncal ataxia. So pretty much just have them sit up. And if they're like flopping or leaning to the side and they need your help, like literally sit up. Like usually that ends up being kind of the break point for me when I'm trying to think about tenectomies. There are some other things too, though. So if it's like vertigo plus, so it's like vertigo and they have a facial droop, or vertigo and like the arm is like a little bit weak, we're probably having a different conversation. And then any up and down nystagmus is necessarily a no. So you can have like, have the move to the side, and you can have nystagmus and stuff. But if it's like rotary, or if it's up and down vertical, then those aren't necessarily, abnormal findings that would prompt. But I would, that what we're saying maybe necessarily, I would almost probably default that like someone who's calling you guys for bad vertigo should at least be considered for stroke and maybe brought to a stroke center so they can hash that out.
Yeah, because that's gonna be a commonly asked question from a personnel, right? Is like, okay, I have this feeling. What's our telltale sign? And that way we just have a common aligned ground that is, if they're having any of that kind of process that we were just discussing with the ataxia and everything else, where it's like, hey, no, like you really need to go to this closer stroke center. That we back that as an organization.
Yeah, and I'll say like it's tough, like getting these calls, like being on the stroke team side of things. Like, sometimes you just don't know. Sometimes what I end up having a conversation with the patient and the families is, hey, it could be your inner ear, or this could be your stroke.
Yep.
And so then we kind of just talk risks and benefits. A potentially somewhat reassuring piece of this is that at least like the vertigo syndromes of posterior stroke tend to actually do pretty well from a recovery standpoint, almost regardless. No time, and so that's why I would do this.
And it's I don't want to say a commonly missed thing, but it hadn't really been highlighted for posterior strokes until recent.
Yeah.
Especially in pre-hospital care environment.
Yeah. I would say it is pretty common. Like of all the stroke syndromes, like posterior is what goes away. Is what falls out across the board at all hospitals everywhere.
Yeah.
Because there's such a differential. It's usually tough to pick out. And so that's where kind of that level of suspicion comes into play with any of those things.
Cool. But yeah, if there's discussion about it, if there's any concern, I would say let someone else have the gravity and the responsibility of making that final determination if it's a posterior stroke or not.
Sure.
If you guys are concerned about it, I would take it to a stroke center. Because these are ones that, we will pontificate on it with our residents too, like teaching it. These are just often tricky to pick up. So. This is just another discussion of some of those stroke syndromes. So like talking about how, and then the other thing too to bear in mind is that there is a right and a left sidedness to the brain. So patients who end up having infarction of the left side of their brain, like a left MCA or left middle cerebral artery, these are often patients who will then end up having some aphasia or difficulty with speech associated with it. You may not see that as much with the right side of their brain.
You were gonna pick the outside.
That I have here. So the big like buckets that these end up being kind of grouped in together. Anterior circulation strokes, these are the ones that we think about, hear about, and we educate the public on the most. So these are usually going to be your ACA, your MCA, and these are, like we said, going to involve the arm, the face, the leg, speech and vision, specifically gaze as well. And this will also be your ocular strokes, because the artery that feeds your retina comes right off of your internal carotid. So if a patient has like painless boom, sudden onset, complete loss of vision, like if you try to even just like wave your hand in front of their eye and they cannot see that and it came on just all of a sudden, that's actually one of the things we worry about having central retinal artery occlusion, which is basically an eyeball stroke. I haven't ever done TPA for those or given like a clot buster for it. I don't know if you have, Dr. Richards.
Yeah, we give
You've done
it
it?
probably several times a year,
Okay.
stroke team. And it's, you kind of hold your breath a little bit. It's nice to have an ophthalmologist to take a look at the eye before, because there are some telltale signs, but really aside from UCMC, you're not gonna get an ophthalmologist there in time, so we kind of just have to go by history and some other stuff, and some that we can kind of see on CAT scan, kind of see maybe on ultrasound, but usually ends up being a risk benefit. The last one I gave TNK to ended up being probably vitreous.
Oh, jeez. Fair. Yep. But that is just one thing too, because we don't talk about vision complaints very often, and I could see someone potentially calling 911 for, I can see nothing out of my eyeball. Most of those I have seen where they end up just walking into the ER, but not outside their own possibility. And then the posterior circulation, like we've been talking about, these will end up being, the worry with them is if they end up involving the brainstem or the pons, you can see like decreases in consciousness. It can inhibit their breathing centers and a lot of their homeostasis. Vertigo being one of the most common symptoms because this also involves the middle ear. And the other thing to bear in mind is that as the axons or like the tails of the nerves exit the brain, all of them cross through the brainstem, the pons, the midbrain, kind of the deeper brain structures. So as you get infarctions in that area, that's why we end up seeing patients have involvement of their arms and legs, because it's basically affecting that same neuron that powers your leg just further down on its pathway leaving the brain. And then the other thing is that in more of those posterior strokes, particularly like in occipitals, they're very deep back in the brain. Those are where you may have patients who have like cortical blindness with it. So blindness from infarcting that part of their brain. Questions so far on any of that? Love the discussion on posterior strokes. They are the ones that I spend a lot of my nightmare fuel on. So exam wise for patients, there's some kind of big buckets that we want to look at for people. And I think if there's anything that we can beef up on, mainly on documentation, but also just for people to have in the back of their minds, it's how you divide up your neuro exam. I break mine up into basically like 4+ big categories. Number one is going to be your cranial nerves, and then this is where I might use Dr. Stothers for some slight assistance. But the big thing, we don't need to in the pre-hospital setting like necessarily drill down and do every single cranial nerve, every single dermatome, every single nerve. I like to do big buckets, and if there's something messed up, then you can hone down a little bit further. So in the face, you want to look for facial droop. When they're talking to you, do you see that there's flattening of the fold alongside of their nose? Can they smile appropriately? And when they're smiling, you want to look at their lower face as well as their upper face, because the forehead has some cross innervation. So if you see that they're able to smile and raise their eyebrows and their whole face is involved with it, that's usually a sign that all the brain is working. If one part of their face is drooping, but they can still raise their eyebrows on both sides, that's actually more concerning for a stroke. Where we see that you have that eyebrow droop is in Bell's palsy most of the time. And that's more of a peripheral nerve involvement, where the facial nerve leaves right by your ear. So it's a more distal compression on the nerve and not usually associated with a stroke. The other one you want to look at is their eye movement and their gaze. I lazily do this with follow my finger. So you want to see if they're going to go up and down, left and right. And then can they do some accommodation where as your finger goes close to their nose, they follow it in. The things you want to look for is, can you get their eye past midline in all of those movements while they're still holding their head still? But while you do that, I like to hold at the extreme of gaze and then see if I have any nystagmus or beating of their eye while they're doing it. And you can do that relatively quickly and hold it there for a couple seconds to see if they have some beating up or down. Vertical nystagmus, like Dr. Richards was talking about, that's where as you have them look up or have them look down, you end up seeing their eye constantly. I've got to do it without moving my eyebrows. Like constantly looking up towards the top part of their gaze. And it's a very fast flicker. That one, every time I have seen vertical nystagmus, it has been something really bad in their brain, like a terrible brain bleed or a terrible stroke. The next big bucket that most of us look at is strength. Most of us will talk about like having them show us your muscles or like, can you do grip strength? And then the other one is looking at their arm or their leg drop. So this is where people talk about having them hold their arms out to test a Romberg and making sure they don't have pronate or drift, or your hand turns and then it ultimately drops afterwards. Lower extremities, as they hold them up, they can have drop with them as well. So when you're testing their lower extremities, you want to have them do it one at a time, keep it up. I actually will like keep my hand up over their foot to make sure that they can hold it up to a high enough point. And you want to watch and see how long it takes for them to go down, if they do at all. Sensation, I usually will like take 2 fingers and I will go on like their arms. You feel me as I'm touching, just going down their arm. And then same thing on their legs, because it ends up being faster overall for them. And then the last one is you want to look at gait. If you can get them to walk, even if it's to the cot, great, because then you have seen them walk. But the things that you're looking for is, are they unsteady? Are they swaying side to side? And then the last one is going to be, if you can, finger to nose, because this ends up helping us see if there's some posterior involvement. And we can show you that with Cody in a second. I found a couple of videos of people demonstrating some ataxia.
The last gait that I'm going to demonstrate is the ataxic gait. In the ataxic gait, the patient has difficulty narrowing the station and maintaining balance. So typically they'll have a wide stance, trying to maintain balance, and that there oftentimes will be unsteadiness in the trunk. So there may be some truncal titubation, which is an anterior posterior pelvic femur at about 3 hertz. And there's also a tendency to lunge or to jerk sideways, and the patient then has to catch themselves. Of course, one of the ways to bring out this particular type of problem is to narrow the station, asking the patient to walk tandem. So if I then am ataxic and then try to walk tandem, then I'm going to have difficulty walking.
Did you respond to my fire alarm?
Westchester Firehouse 74, Lieutenant Asbrock.
So no joke, that's what my first posterior stroke looked like, and that was the key, that he walked like that. I'll never forget it. This was another one that I saw with a patient with a walker. Oh, heaven's sake.
It's only 5 seconds.
Go away, Freddy's. All right. And with this one, what I like is you can actually see like how much she has to keep her legs out. And if when she's facing, you can see that her whole trunk ends up kind of undulating with it.
will say it is also very helpful when they have their abnormal exam finding written on their shirt. So if you could pull your
Yeah.
picture like that, I would recommend that.
All right. Try to see where I had stuff added here. Cody,
Yes.
do you mind doing me a favor?
So-
Can I have you sit up here for a second?
You want to stop the
Yeah,
slide
I can
part?
see you.
Yeah.
We can make that.
Yeah, can you guys see Cody there in the back?
Yeah, but maybe do like stop share so
You gotta stop
there's
share.
their screens bigger.
Anyway,
They should be able to see us.
Yeah.
Even though we can.
Hi.
are you able to see them okay?
Perfect.
Perfect, okay, cool. So Cody, you do me a favor. First off, raise your eyebrows for me. Cool, smile big for me, show me your teeth. Stick your tongue out, move it from side to side. Good, can you say it's always sunny in Cincinnati?
It's always sunny in Cincinnati,
Where are we at right now?
Westchester.
Excellent, do you know what day it is today?
I don't know what day it is.
Me either.
It's Monday.
Excellent. Put your arms up like this for me. Hands up to the sky like you're holding a big tray. And I want you to keep them up there for 5, 4, 3, 2, 1. Good. Take that pointer finger and I want you to touch your nose and then touch my finger as fast as you can 3 times. Good. I want you to do the same thing on the other side. Nose finger, nose finger, nose finger. Good. Show me your muscles. Push me away. Pull me back in. Good. Do you feel me touching on both sides?
Mhm.
Does it feel the same? Okay, squeeze my fingers tight as you can. Good. Swing your legs up there for a second. Have you lift this leg up and keep it up for 5, 4, 3, 2, 1. Good. This one up for 5, 4, 3, 2, 1. That's my pre-hospital neuro exam for people. You go head to toe. And the nice thing is that if you have it split up, where you have them do a Romberg first, and then do finger to nose, and then you go to strength for them, you actually end up catching a couple of those posterior signs on them without having to take a lot of time doing it. And it hits a lot of the big NIH stroke scale stuff. And then the last one would be follow my finger. Good.
I didn't have some.
I saw you were trying to do that. The other thing that, the other thing that we want to watch for in our patients who are worried about a stroke, can you show me a drift in the drop?
Yeah, sure.
Pick an arm. All right, so have you keep your hands up here for 5, 4. So the first thing that happens with patients is when they have their arms up, we'll see them do a drift. So they'll have pronator drift where their hand turns in. And then they'll eventually lose strength and they'll drop. If you have a patient who has like complete loss of strength, so classic on that side. So if you have them where you ask them to lift it up, this is where you feel a little bit mean, but it's really helpful if you actually take their hand up and force them to prove that they are completely flaccid. So you can hold their hand up for them, and then if they end up dropping it, or if you see them hold it up and try to resist for a few seconds, when you let them go, you'll see that they try to hold it for a little bit and then they go down. Same thing on the lower extremities for patients.
If you really don't trust them, you can hold it over their face.
That's correct. I did that recently, actually, for a patient. That's what's really fun. And then what Dr. Richards was talking about with the truncal ataxia for them. This is where like you'll literally try to have them stand up and they end up having like a lot of, or even just sitting up where they end up having a lot of unsteadiness for them. The ones that I've seen, they end up like actually like undulating kind of all over the place. And it's not their legs are not necessarily moving with it. It is their trunk that ends up having the problems with it. Cool.
Perfect. Thanks, Cody.
Beautiful. I hope it shows you which screen you're sharing, just in case there's something you don't want to share with them. All right. Come on. We talked about them a little bit before, and I saw that everyone was using the Cincinnati pre-hospital stroke scale. And this is what we alluded to earlier, that all of our, like, first of all, the Cincinnati stroke scale has been very well validated. I actually found a Cochrane review that showed that, like, comparing it to some of the other pre-hospital stroke like screening tools, the Cincinnati stroke scale had the best sensitivity for finding patients with an LVO, particularly the anterior circulation. But when we look at it, what is the big things that are involved in it? Facial drift, arm drift, and speech. And this is what we train people to look for in the public as well. But it doesn't include things like gait, dizziness, changes in vision. So that's why, and those are more posterior stroke symptoms for people. So that's why we wanted to spend a little time on that today. There's an LA stroke scale, which also still looks for things like grip strength, smile, arm weakness. So again, more anterior symptoms. And probably part of the thought of this is that we're trying to find these LVOs that can be intervened upon with thrombectomy and or TPA. But this, you guys are all correct that it does not include posterior stroke symptoms. Similarly, NIH stroke scale, for patients, it also does not really include anything on the posterior circulation. It does help you narrow down some more concerning features though. I like to break it down into their level of consciousness. That's where I said that 4+. So, you've got your cranial nerves, your strength sensation, ataxia, and then the plus is their overall like ability to speak, answer questions, interact with me on exam. We've all seen those patients where you ask them, where you have to like keep poking and prodding them to stay awake, or they're not able to get words out to you, they're not able to follow commands. And those are more concerning for a stroke that's involving the speech and the thought process part of the brain. Then you've got your vision or your gaze and your face. So all of this being above the head. And then you've got your arm or your leg, your sensory, your ataxia. And then there is some dysarthria there as well. And then some language. You can test that language just by asking them the main questions. All you need to say is like, what's your name? Where are we right now? I don't know, what holiday just passed? Something that's a current event that they should be able to know. And if they can get 2 of them, they actually score well on the NIH stroke scale. But again, there's nothing about dizziness, there's nothing about nystagmus, and there's nothing about ataxia on here. And those are gonna be some of your big ones if you're looking for posterior pathology. So, in your like abbreviated NIH exam, this is the one that I'll do for patients when I see them at the door, is like, tell me your name, tell me where you are. And then the other thing you can do to help keep an eye on their gaze is watch their eyes as you're walking around the room. Like if you go from one side of the bed to the other, I'll do this intentionally, like while we're getting them off the stretcher at the CT scanner. And I do that because I try to get them to follow me and ask them questions while I'm walking around the room. In a patient who has hemi-neglect, they will not be able to go past midline for them. Even if you like snap your fingers right next to their eye, or you give them, my other favorite one, sorry, Cody, is, so say you have a hemi-neglect over on this side. What you can do for people is you can actually try to get them to blink by coming in with your fingers at their face. No one likes it, sorry, he's being a really good sport. But in patients with a true hemi-neglect, they will not see you coming until you go on the side that they are not neglecting anymore. So that's why like I'll oftentimes go on one side of their head and like try to talk to them over here and be like, come over, look at me, to try to help suss out how bad the involvement is. Follow the finger to look for nystagmus, show me your smile, put your arms up with your Romberg with it, raise your legs. Noxious stim is, it's basically touching them, like can you feel me as you touch your arms or touch your legs? And then finger, nose, finger as a sign for some posterior circulation, and walking if they're able. I realize not everyone is, but if you can even get them to walk to the cot, clutch. And then the other thing that we talked about at the beginning is having some awareness of non-stroke falls that may be from a stroke causing it. These are things like an altered mental status patient who they're not speaking, they're drooling, they're not able to say appropriate words because they've infarcted that part of their brain. Low mechanism trauma, so things like ground level falls, or unfortunately MVCs for people, or someone who's found in a car or just outside of a car, slopped over, but doesn't fit with them having had a severe enough impact to cause them to have that nasty of a neurologic insult. Stroke should be on our list of things to at least evaluate for those patients. Found down's a huge one. So people who, they may even have been down on the ground for a long time. And it's because they ended up having either hemorrhagic or ischemic stroke that caused them to no longer be able to get up and move around. So those are patients who they've been on the ground for a long time, or someone found them down, we don't know their last known normal. It's really helpful for those to have stroke on your list of potential causes for it.
For the posterior stroke, just the call could just be vomiting, which is terrifying.
Yes,
Yeah.
vomiting or dizziness, because they will have usually such bad vertigo that they'll just be constantly vomiting, and unfortunately Zofran doesn't make it a lot better for them either, at least in my experience.
The other kind of like bummer, and I mean, granted, like American Heart Association, American Heart Stroke Association does awesome stuff in terms of like public outreach, but like,
Then it's one is 74 town, 73, fire alarm commercial.
but
I mean, one
some of the challenge with like the messaging is that like they've done a really good job of like messaging like cardiovascular risk factors kind of stuff. And so sometimes that gets conflated. So like someone will see like their mom having a stroke and they'll call dispatch and say, hey, I think my mom's having a heart attack. We need and so like the call taker will hear heart attack, will
Yeah.
figure that as a cardiac complaint, show up on scene. It's like, no, that's actually a stroke. And then you're just kind of like behind the Q8 ball. So, I mean, it's good that they're calling 911, but be aware that there is some confabulation, I think, in how people describe this.
Excellent,
Good.
thank
Yeah,
you.
for sure. And then with the gaze stuff too, probably important to note with CSTAT that the gaze is 2 points right off the bat. So I mean, that'd be a positive for CSTAT for an LVO as well.
Yep.
Yeah, like the fixed gaze deviation is bad, no matter what it is.
Yeah.
It's bad.
No bueno. No bueno. Okay, the management on the pre-hospital side, I was trying to go through the Southwest Ohio protocol, and most of it it focuses on primarily recognition for people, running it through Cincinnati stroke scale, and then notifying a potential receiving facility of a patient that you find. The other things that go into this though for patients is what we've talked about before, getting a glucose, because glucose abnormalities, since that's the brain's only form of nutrient it can really use, if it's too low or too high, they can have neurologic symptoms, and it's good to know that ahead of time. And then last known normal. The thing with last known normal to make sure that you suss out with patients, most patients will tell you most people may tell you when they found the patient, but that may not be their last known well. So like if they found the patient 45 minutes ago and decided and noticed that at that time, grandma had a droop on the one side of her face, and I thought maybe she took a nap and it got better. That's not really the last known well. That's the time of symptom awareness, for lack of a better word. But last known well, maybe 8 a.m. this morning when Mima came down to get her medicine out of the cabinet and said hello to her granddaughter or her son-in-law. And those are things that are really helpful. And that's why you may have a ER doc who is maybe getting a little aggressive, where they're really trying to suss out the difference between the two, because our treatment depends very much on their last known normal, not necessarily symptom discovery time for people. And then getting them to a stroke center capable of managing patients. The other thing for some patients that I thought was worth mentioning is getting your exam, but then also making sure their airway is appropriate. Some of these severe stroke patients, if you have vigilant monitoring of their airway, you may not need to intervene upon it. Some of the much more severe, bless you, stroke patients may need to have intubation performed for them, or notify the receiving hospital, hey, we got someone coming in who we're worried about an airway. The other thing too that is worth noting is their blood pressure. We cannot do TNK or thrombolytics for patients until their blood pressure is below 100, I think it's 185.
185 or 110.
185 over 110 before they can get a thrombolytic. So I caution people in the pre-hospital setting of necessarily reflexively treating that blood pressure, but it is a thing to make sure that we have people aware of at the receiving hospital, hey, this patient's 200 blood pressure before they show up, because sometimes that may be what their body needs to perfuse a little bit until we have a better idea of what's going on. What's your take on pre-hospital blood pressure management? This comes up all the time whenever I talk to people about it.
Yeah, just be aware of it. It's not something to treat. Any study that's looked at pre-hospital treatment across the board, that hasn't really panned out. So we're just gonna be aware and see if it will need to get treated once it gets there.
Cool. And then the other thing that I wanted to spend a little bit of time on, because I have done this with Westchester before, so I know it is something that can happen, is if you end up having to take a post-therapy patient. This was actually my second air by ground, is when we had to take a patient who had got TNK down to UC Maine for thrombectomy and admission to the ICU. And I, having read through stuff for air care last year, I know that this happens maybe once or twice a year where this happens. So I think it's worth for us to be aware of what we need to do for these patients if we end up transferring them on an interfacility basis. So the main reason these patients would need to go downtown, number one is ICU management after getting a clot buster. They need very frequent neuro monitoring and neuro exams, as well as incredibly close blood pressure management to prevent some of the deleterious effects of receiving a clot buster. The other reason we may take them downtown though is their thrombectomy, either for a person who has been outside of the intervention window for receiving a clot buster, but there is still inside of that thrombectomy window, and thrombectomy is done down at UC. As a reminder for everyone, the clot buster or TNK can be done within 4 hours of their last known well. Thrombectomy now can be done up to 24 pretty safely for people. So just because they woke up with it doesn't mean that they necessarily will not be able to have an intervention done for them. But these are both time-dependent interventions, which is why we may need help getting them down to UC potentially.
And thrombectomy at Westchester Hospital is on a visible horizon. So it's not in here, but next calendar year, hopefully early next calendar year, there'll be an option, but we'll message that one in there.
Really? That would be cool.
Up here. I know it's been being discussed. Okay.
Oh, that'd be sweet. That'd be awesome. And
We'll, yeah. When it becomes concrete, we'll let you know, because
Yeah.
we hear it as well, that it's always been a little bit of a moving target, but it has been a much more redoubled effort.
That's exciting though.
that is
Definitely
cool.
is, absolutely.
That's fantastic. TNK, this is the medication in the Ohio area that we use as our thrombolytic or clot buster. We used to use TPA. We have moved away from that now and gone on to TNK. But this is a medication that goes to cleave plasminogen bonds on clots, causing them to break apart. The one downside of this is that it will cleave like pretty much any clot in your body. So there are some risks, some very clear exclusionary criteria for people to get this. The other thing to bear in mind is that TNK can be used for both a stroke, but also for heart attack patients. And the dosing is different for those. Heart attack patients get the max doses is 50. For stroke patients, their max dose is 25, and it is a weight-based dosing. The one nice thing though, is that we will not have to deal with this if we're transporting these patients, because it's no longer a drip. It is a one bolus and then you're done with it. And then you're on to the post-administration monitoring phase for patients. If you're picking this patient up though, it is good to know what dose they got of TNK. And if this is done, say in conjunction with air care or having another doc on board, they should be aware of this dose for their patient as well. There are complications for people getting a clot buster. I like this infographic for people because it's a good visual presentation of what happens for people. So like out of 100 patients that end up getting a clot buster, you'll have about 10 to 13% that end up getting completely better. You'll have, I think it's about 25% or so that end up having significant improvement, but not complete resolution of their stroke symptoms. A bunch of people with no benefit. You'll have some people who got worse, about 3 of them, and then one person who may be severely disabled or die after receiving the clot buster medication. And the thing that we worry about is because we have given them a medication that will lyse any clot in their body, there can be some conversion, and you have this brain tissue that had a clot that was preventing blood flow to a part of the brain that was dying. Once you release that clot, you now have this weak brain tissue with very poor membranes that once the blood flow is restored to it, it will burst open and cause them to have a bleed. And that does happen for people. You end up having these about that 2% that end up having some worsening symptoms. This is the thing that we worry about the most for them. There is also a concern for patients having systemic hemorrhage. So say if they had an undiagnosed like gastric ulcer or bleeding elsewhere in their body, they may have some bleeding from that after receiving this medication. And there is cases of angioedema after receiving TPA. I think it's about similar for the rate of it with TPA and TNK, at least from what I could find. I don't know if you've had different experience with
Two
it.
drugs is about.
The same. So if you see your patients that are now starting to swell up afterwards, that is one of the things to be cognizant of with it. The NIH stroke scale, for patients who have just received this medication, they do need to have monitoring, and it is on a very regimented basis. Usually this, like for the first 2 hours, every 15 minutes, having one done is usually done in the emergency department or when they get to the ICU. After that first 2 hours, it's every 30 minutes, they need to have an NIH stroke scale assessed on them. Which is why oftentimes you'll have a critical care transport team that goes along with this to help getting this done while you're monitoring them. And then up to 24 hours, they have to have it every hour. There is some discussion about potentially cutting back how frequently we do this, but we are not there yet. And the reason it's done that frequently is to, if there is a complication like a post-lytic bleed, we want to catch it early so we can intervene upon it relatively quickly for patients. And then the other big component of this is blood pressure control. So patients, to get the lytic in the first place, their blood pressure has to be less than 185/110. And then after they get it, we want their blood pressure to stay less than 180/105. So that's why some patients, when they get to the hospital after we see that they have a stroke or that we have concern, they're now a TNK candidate. You may see them get a dose of labetalol, or you see them put on a nicardipine drip, a calcium channel blocker, so that we get them to a blood pressure level where they can get this medication. The worry is that if we don't watch this blood pressure really closely, we put the penumbra at risk, or that area around the area that has been damaged. Those blood pressures already are trying to do some regulation to limit how much unnecessary blood flow is going to them. So you'll try to get some high blood pressure with it, but with those damaged blood vessels and damaged tissue, they can end up having some leakage, some edema, some actual conversion into hemorrhage. And we found in the literature, keeping people's blood pressure at a slightly lower level with it allows them to perfuse their brain as best they can without putting them at severe risk for other complications that we talked about. And then the interesting thing that I think is worth pointing out to people, the blood pressure that you really worry about for these is actually diastolic blood pressure, because that is the pressure that your body is seeing constantly all the time. So when I transport these patients, we'll often have where we treat their systolic blood pressure and we get that less than 180, but their diastolic blood pressure is still high. And that is the pressure that is constantly being thrown at your blood vessels and your tissues all the time with these surges of high pressure on top of it. So we want both of those to go down to protect the brain tissue that's at risk. That's the big stuff that I have. Questions, comments, concerns, other thoughts?
No, I think you hit all the real high important pieces of this, especially those kind of unusual or not anterior circulation syndromes, because that's really kind of where your all clinical experience, training, acumen comes into play. Because it's, I mean, for the left MCA syndrome, they're not moving aside, like most of the time you pick up on that, right? And then it just ends up being like, all right, how can we efficiently go through the process?
Yes.
Just for those other ones, especially the posteriors, the brain stems, the pontines, the thalamics, these sort of things that are just like weird neuro something going on, having a high enough suspicion and calling it as such is really kind of where the needle can get moved on the pre-hospital side of things.
Yeah.
Any other questions from the companies? All right,
Cool.